Okay. So yesterday, a very interesting question was asked on ICU forums, icu.in/forums. One of the member asked that why we don't give atropine once the pupils are dilated in OP poisoning, means in organophosphorus poisoning. Why we stop atropine when the pupils are dilated? So basically, this is a very important question and very good question. So you need to understand the mechanism. In organophosphorus poisoning, basically your acetylcholinesterase is blocked and there is a cholinergic crisis. The patient is having secretions everywhere. Parasympathetic nervous system is stimulated, uncontrolled. So you have bronchoria, you have lacrimation, patient is having diarrhea, sweating, and bradycardia. All these things are there. So the atropine, what helps is the atropine helps to decrease this cholinergic crisis and control the symptoms. So there are only two indications which for which atropine should be given, and it should be targeted accordingly. So those two symptoms are: one, bronchoria, chest respiratory symptoms, means if the patient is drowning in his or her own secretions, patient is having crepitations, atropine should be given till the time the respiratory secretions are dried up and patient is comfortably from respiration point of view. Second is if the patient is having hemodynamically unstable bradycardia. Simple bradycardia, don't give atropine. But if the patient is unstable bradycardia, means heart rate is below 60 and the BP is also low, 80 systolic, 90 systolic. But if the heart rate is around 60 and blood pressure is maintaining around 100, 110, then you should not give. So only two indications for which, according to which you should titrate atropine: dried up bronchial secretions, patient should not have bronchoria or respiratory distress, and second is hemodynamically unstable bradycardia. Other parameters like dilatation of pupils, lacrimation, diarrhea, these are all or should not be used as a therapeutic target goals when you are atropinization, because atropine itself causes delirium and other side effects which is very difficult to control. So I hope pupil size should not be a target for atropinization in OP poisoning, but usually where the resources are less, staff is low in peripheries at times, pupillary dilatation is a fairly good enough marker that we are atropinization the patient, or if the pupils are dilated, sufficient amount of atropine we have given. That's why it was used for long period of time. This parameter was used. But those who are listening, you go and read from any book of whether it's an O's manual or Harrison or up to date. Anywhere you will read or articles on the net, you will find only two indications for which atropine should be given. One is hemodynamically unstable bradycardia and respiratory bronchoria. If these two are okay, you can decrease or can stop atropinization and assess accordingly. So do read more about this topic. Thank you.